I'm Archie Palm. I have Jenna Khan on with me. We are very excited to be co-hosting this Rover session with Ilrag. We'll be going over hematologic malignancy lymphoma cases. We have our wonderful Rover resident, Dr. Ryan Hutton, who will be moderating the session. So before I give the floor to him, just going over a few logistics, we'll have poll questions throughout the session. So please answer those during the cases. And if you have any questions, please put them in the chat. It's on the bottom of the Zoom screen. And when you do put in your chat questions, make sure to address it to everyone. I think the default setting is hosts and panelists, so you'll have to switch it to everyone so that everyone can see the question and benefit from the answer. So anything else, Jenna, before we let Ryan take over?
I think that's it.
Okay.
All right, great. Thank you. Well, thanks to everyone for joining today. We have a great panel. So I'm just going to do quick introductions. So we have Dr. Leslie Ballas from USC, Dr. Brandon Imber from Memorial Sloan Kettering, and Dr. Yolanda Singh from University of Washington. I'll ask each of the panelists just to quickly introduce themselves first, and then we'll dive right into the cases. So Dr. Ballas, why don't you start?
Hi, I'm Leslie Ballas. As Ryan said, I work at the University of Southern California in Los Angeles. We were prepped to tell you why we chose to go into radiation oncology. Out of medical school, I actually matched into general surgery and switched to radiation oncology when I finally saw the light, so to speak. I did that mostly because of the longitudinal care I get to provide my patients, and I really enjoy both palliative care as well as definitive management of cancer patients.
Great. Dr. Imber?
Thanks so much for having me. I really appreciate it. I'm Brandon Imber. I'm one of the junior attendings at Memorial Sloan Kettering. I trained here as a resident as well. I had sort of a similar path, actually. I was interested in neurosurgery and took a research year in neurosurgery and was pretty convinced I was going to do it, and realized that I really liked oncology more than the neurosurgical aspects of it, and sort of made my way into rad-onc that way. I think they asked also why heme. I had a really outstanding mentor when I was a resident who took an interest in me, professionally, and really tried to push me in sort of every dimension of my career. So it made a lot of sense to stay in that area. So love what I do now.
Great. And then Dr. Singh.
Hi, I'm Yolanda Singh from the University of Washington and Fred Hutch Cancer Research Center. I stumbled into radiation oncology, kind of like many of you have, but actually it was in the setting of a sarcoma clinic where it was multidisciplinary, and just seeing the surgical oncologist, medical oncologist, and radiation oncologist like standing around this patient was actually a very impressionable kind of experience for me. Why hematologic malignancies? I think very much like Dr. Imber, I was very inspired by an excellent role model mentor of mine when I was in training. And I think the other aspect I love about hematologic malignancies is that we can treat everywhere. And so it's no cookie cutter approach. It's fun one time to be treating a mesenteric mass that's moving, and then creating a spinal radiation, and then the eye, for example. So I always feel like I'm always learning with the patients that I'm seeing in clinic.
All right, well, let's just get started. So like Dr. Palm said, I'm Ryan Hutton. I'll be moderating today. I'm a PGY4 resident at the University of Utah, so happy to be here today. So Dr. Ballas is going to present our first case, so I will hand it over to her.
Thank you. The first case is a 24-year-old man who presents with redness and a bulge in the left medial eye that increased in size over the course of months. You can see a picture of it there. He had a full workup, and ophthalmology performed a biopsy, which revealed an atypical submucosal lymphoplasmacytic infiltrate, which is morphologically consistent with an extranodal marginal zone lymphoma or MALT lymphoma. And you can see the flow cytometry results there. This brings us to our first poll question. What would be your plan for treatment?
I think there's about 20 seconds or so to let participants vote, and then it'll show the results.
Okay, so we had 42% of our respondents say that they would give 4 gray and 2 fractions. 21% would do 24 gray and 12 fractions. And then a smattering of folks would do either no treatment or some form of systemic therapy. I think that sort of the question at hand, if you were to choose to give this patient radiation, which I think a lot of us would do, is do we give 24 gray and 12 or 4 gray and 2? And that's a area of debate. And so I wanted to sort of discuss the rationale for the dosing. The first major dose reduction study was a phase 3 randomized control trial looking at 40 to 45 gray versus 24 gray in 2 different cohorts, indolent lymphomas and aggressive lymphomas. And this was done by the British National Lymphoma Investigation Group led by Dr. Lowry. There were 361 indolent lymphomas included. 59% were follicular, 20% MALT. What they found, and you can see from the in the Kaplan-Meier curves on the screen, is that there was no difference in terms of freedom from local progression or progression-free survival when they compared the 24 gray versus the higher dose. And from that study, I think most people started to give 24 gray to indolent lymphomas. Similarly, another study by Jurinsky et al. Looked at sort of palliative radiotherapy in the setting of indolent lymphomas and specifically in follicular lymphoma, and used the famous boom dosing of 2 gray times 2. And so you've got sort of these 2 lower dose levels that then got evaluated and compared in a randomized control trial, the FORT trial. This was a phase 3 randomized control trial looking at 4 gray versus 24 gray in indolent lymphomas. It included 86% follicular lymphoma, 14% MALT lymphomas. The long-term data from the FORT trial was presented in 2021, and they showed that there was the local progression-free survival for 24 gray was 94% versus 70% for 4 gray. There was no difference in 2-year overall survival. They did do a subset analysis looking at whether or not the dosing made a difference in the follicular patients and the MALT patients, and they found that there was very similar results as presented in the overall cohort, which you can see in the Kaplan-Meier curve. They did do a post-hoc subset analysis of orbital disease, and the reason that they looked at orbital disease specifically is that there were a number of single institution studies that had been reported, Stanford, MD Anderson, looking at specifically 4 gray for orbital adnexal MALT lymphoma, showing overall response rates of 96+% with complete response rates at about 85%. And what they found when they did this subset analysis on the FORT trial was that progression was seen in none of the 20 patients who got 24 gray, but in 2 patients out of the 13 that got 4 gray, and that the progression was late, 5 to 6 years later. When we look at late follow-up, they did continue to see a reduction in local control with 4 gray. It was at about 80% at 2 years, but went down to 70% at 5 years. And they did not see that same decline in reduction in local control when looking at the 24 gray cohort. And so their conclusion was that if durable local control is the goal, 24 gray is the preferred dose. And so I think then we have to ask ourselves, is 4 gray really only for palliation based on the FORT data? And I think part of that question comes from, is local control is that our only endpoint, when we're concerned about non-Hodgkin lymphomas, when disease progression is, going to be likely to be outside the radiation field sort of anyway. The Memorial Group, led by Dr. Imber, did a retrospective study of 299 patients, which was the largest single institution retrospective study for use of lower doses in indolent non-Hodgkin lymphomas. They included 66% follicular lymphoma patients, 27% MALT patients, and of note, it did include 17% cutaneous patients. With a median follow-up of 2.4 years, they showed an overall response rate of 90% with a complete response rate of 68%, and local progression in about 25% at 2 years. Of these patients, 39% ended up going on to additional radiation or systemic therapy. When additional radiation was given, about 30% got another 4 gray, 24% 24 gray, and 24% 30 gray. And the response after additional radiation was not too dissimilar to the efficacy in the first course of radiation therapy. And the Jurinsky group had similarly reported this same finding. They did find that pre-treatment size of disease was associated with response, and only 4% of their patients transformed to diffuse large B cell, and all of those transformations were outside of the 4 gray treatment site. And so I think that, in my mind, while 24 gray provides more durable response, 70% of those who are getting 4 gray remained controlled at 5 years. And since there's a small risk of transformation, our treatment practice has been to give less dose with the knowledge that we may have to come back and give more later. I think that 4 gray for non-Hodgkin lymphoma is being looked at in a number of different settings. There's been reports on using that for Brian, maybe the next slide if you don't mind. Yeah, in orbital adnexa, in salivary gland, MALT lymphoma. I think that the MD Anderson group has even looked at gastric lymphoma, gastric MALT lymphoma, excuse me. It's been used in relapse refractory mantle cell and even lower doses in total skin. The question sort of exists: can you use this 4 gray in other hematologic malignancies beyond just indolent non-Hodgkin lymphoma? And we have a current multi-institutional trial looking at 4 gray in multiple myeloma, which I would say is not ready for prime time and certainly not the recommended dosing outside of that trial, but it is certainly being evaluated. When we talk about the challenging aspects of this case in particular, I think we need to sort of weigh need for retreatment, stress for the patient, continued access to good ophthalmologic care with that extra dose of radiation. And as I said, our approach is to give 4 gray with retreatment as needed. And ultimately, this is one of those areas where shared decision-making with the patient is really key. Yolanda, Brandon, what are you guys doing for these, sort of conjunctival or orbital molds?
So assuming the patient undergoes staging and it's the only site of localized disease, I'm old-fashioned. I've been still going through with 24 gray and 12 fractions. But in some select patients with lots of comorbidities, older age, concerns about being able to get to and from treatment, we definitely have considered the 2 gray times 2 approach as a response adapted. We'll reassess in 3 months to see, and if they've had an inadequate response, we'll go to a higher dose at that point.
I would say that most of our patients are probably starting with 4 gray at this point, and we're doing the response assessment like Dr. Singh just described. I would say it would have to be a very bulky or very atypical case for us to start with the 24 gray at this point, unless the patient was really adamant that that was what they wanted to start with.
Yeah. So we do that response adapted treatment, and if you can go to the next slide, we follow these patients very closely in clinic. And so this patient opted for 4 gray after we discussed the options. And so you can see at 1 month after treatment, there's obviously still disease there, although less, certainly less. And by 5.5 months after radiation, you can see that the disease has really minimized considerably. And so we see them, ophthalmology continues to follow them, and this patient did not need further retreatment. Thank you.
Great, thank you, Dr. Ballas. So we're gonna save like group discussion for the end if there's time. So unless other panelists have something to jump in on, I'll switch over to Dr. Sang in case number 2.
Thanks, Ryan. So we'll switch gears a little bit and we'll be talking about Hodgkin's lymphoma early stage and approaches to selecting patients for advanced radiation techniques, specifically proton therapy. So this is a 53-year-old female who presents with right neck fullness and eventually palpable adenopathy. And you can see on these coronal neck CT scan disease or lymph nodes within the right cervical and supraclavicular chain. She undergoes an excisional biopsy, which shows classical Hodgkin's lymphoma, nodular sclerosis subtype, and it's positive for CD30. It doesn't have significant CD15, and it's negative for CD20. She has no fevers, chills, drenching night sweats, or weight loss, and her ESR is 53. Of note, she does have a family history of an extensive breast cancer on her mother's side, spanning back 4 generations. So this is her staging PET CT. On the left here is her maximum intensity projection scan, and then on the right, the fused PET with CAT scan axial images. And you can see her disease spanning the right neck, supraclavicular, and to the axillary region. On the left, you can see the low left supraclavicular region is involved, in addition to the mediastinum and the posterior mediastinum. And then on the right there, you can see this yellow arrow pointing to this lower paraesophageal lymph node. It has an SU max of about over 3, so it was mildly FDG avid and corresponded to a gross lymph node on a diagnostic scan. So our first question for this case would be, what stage and risk category is this patient? So options are stage 1 versus stage 2. And then in terms of risk category, favorable versus unfavorable.
And while that's going, there's a question. Do you treat stage 2E cutaneous B-cell lymphoma, lymph nodes involved with radiation if a complete response is obtained after R-CHOP?
So I can let other panelists weigh in, although Jenna, I'm just trying to be for interest of time. Do we want to put this toward the end?
Maybe one of the panelists can answer it in the Q&A part.
Okay, thanks Jenna for clarifying. Okay, so we have here that the majority think that this may be a stage 2A favorable and then 43% stage 2A unfavorable. So in terms of the stage, all the diseases above the diaphragm, so stage 1 or 2, but she has more than 1 nodal site, so she's stage 2, and then the A designation being because she has no B symptoms. In terms of favorable versus unfavorable, as you may know, there are multiple definitions depending on which cooperative group trial you're looking at. For practical reasons, I just memorized the one for the German Hodgkin study group, and the reason for that is, to my knowledge, it's the only one that if the patient meets all the criteria for favorable, we can actually de-escalate the number of chemotherapy cycles and dose of radiation. So as a reminder, the German Hodgkin study group definition, you have to have all 4 criteria, which is no bulk, no extranodal disease, ESR is not elevated, and 2 or fewer nodal sites. So for her, she actually has more than 2 nodal sites, so bilateral neck, axilla, mediastinum, and then her ESR was elevated, it was 53. So she's actually stage 2A unfavorable. So the backbone of treatment for these patients will be ABVD chemotherapy. So that's adriamycin, bleomycin, vinblastine, and dacarbazine. And she actually initiated therapy on a clinical trial. So she had a slightly modified chemotherapy backbone. It's AVD, so the bleomycin is omitted. And in lieu of the bleomycin, she gets brentuximab vedotin. And this is an antibody drug conjugate. And the antibody here is anti-CD30. So remember, classical Hodgkin's lymphoma, CD30 positive. And it's actually conjugated to this payload known as MMAE, which is a microtubule inhibitor. And then she also gets an immune checkpoint inhibitor, nivolumab. Unfortunately, about 1.5 cycles in, she is hospitalized for neutropenic shock from MSSA bacteremia, and she's noted to have a reduced ejection fraction, now 27%. And her new systolic heart failure is thought to be maybe potentially multifocal in etiology. So she has sepsis that may have caused some stress cardiomyopathy, but also, as a reminder, doxorubicin in itself can cause chemotherapy-related heart failure. So suffice it to say, she's not a candidate for any additional anthracycline-based chemotherapy, and so she's transitioned to brentuximab dacarbazine for 3 more cycles. Shown here are her MIP scans before and during chemotherapy. So as a reminder, on the left is her pre-chemotherapy PET showing the initial extent of disease. She fortunately has an excellent response after 1.5 cycles of AVD-BV-NIVO. So she actually attains a complete metabolic response that's actually still sustained after 3 cycles of BV dacarbazine. So, you know, the question here is what to do next. And we decided that stopping, even though she had a complete metabolic response, was probably inadequate. So BV dacarbazine is a less intensive chemotherapy compared to ABVD. And so at this point, we transitioned to radiation. And I wanted to just briefly review that there's strong data supporting the use of radiation, even in the setting of a complete metabolic response. So the UK RAPID and ERTC-H10 studies both included patients that had unfavorable early stage disease and tested a concept known as response adapted therapy. So the idea is that patients would get a number of cycles of ABVD, and then they would get a PET-CT scan. And if their PET was negative, in general, we think about these patients as having a good prognosis. So these studies then tested, well, can we safely de-escalate therapy, in this case, omit radiation, without compromising outcomes? So in both of these studies, they were designed as a non-inferiority study. So the idea is that you're willing to accept a decrement in your progression-free survival because you're de-escalating therapy. And so, for example, in the UK RAPID study, they were willing to accept a decrement of up to 7% in the 3-year progression-free survival. In the ERTC-H10 study, they were willing to accept a decrement of up to 10% in their 5-year progression-free survival. But as you can see on the lower row results, both of these trials did not meet its non-inferiority endpoint. So the UK RAPID study, the difference in progression-free survival was 3.8% favoring radiation, but you can see the 95% confidence interval, it exceeded the pre-specified non-inferiority margin. And for the ERTC-H10 study, they actually did an interim analysis and they declared futility. They actually closed the trial early because of the increased number of events in the no radiation arm. So both of these studies clearly support that radiation cannot be safely omitted after ABVD chemotherapy, even with a negative PET-CT scan. So my recommendations for her were 30 Gray involved site radiotherapy, and I would estimate her progression-free survival benefit on top of chemotherapy to be probably at least 7 or 10%. So definitely on the higher end because her initial chemotherapy was not as intensive compared to ABVD. And so the question now is kind of how do we consider patients for different advanced radiation techniques? And I thought she would be a good candidate for proton therapy for a couple of reasons. The first is with involved site radiotherapy, we're treating the initial extent of disease because that it will help inform kind of what the acute and late toxicity will be. In the setting for her, she has lower mediastinal disease, and I'll go over in a few slides kind of that formal definition of what lower mediastinal means, and axillary disease. And based on several dosimetric comparative studies and just kind of anecdotal experience, we found that these patients actually have lower lung, breast, and heart dose with protons compared to photon treatment. And that's significant because we know that the lung dose can influence risk of pneumonitis, the heart dose, risk of cardiovascular and valvular heart disease. There are other clinical factors that also may feed into the decision-making process about who may benefit from protons. For her history of systolic heart failure and then her older age, so remember she's in her 50s, she's not in her 20s or 30s, means that she already has a baseline higher risk of cardiovascular disease. So any incremental relative risk reduction we can do for toxicity improvement will have a bigger impact in terms of absolute risk reduction as well. And the other consideration is secondary cancer. Now, one would argue for someone who's quite perimenopausal or postmenopausal, she's 53, that the breast cancer risk may not be as great because her fertility lifespan is much shorter. So we know that is pretty much gone. So someone radiated in her 20s is going to have a higher breast cancer risk compared to someone in her 30s or 40s. But remember, she actually has a family history of breast cancer, and there's nice data from Europe, population-based data suggesting that a family history of breast cancer also has predicted for higher risk of secondary breast cancer among Hodgkin lymphoma survivors. So why proton therapy? I'm just going to show this obligatory percent depth dose curve on the right. And so the dashed blue line is a percent depth dose curve for photons, and then the solid black line is for the spread out Bragg peak. And I think it's pretty obvious that the dose beyond the spread out Bragg peak, that the difference in the area under the curve is the dose that you would be saving with protons. But there's also dose at the entrance, and I don't know, Ryan, if you can just point to it. Yeah, right there, where that the blue line is above the black line. So that's potential dose that you're also saving or minimizing to the patient. Though it should be noted that the skin dose with protons is hotter compared to photons. Thanks, Ryan. So now we're going to talk a little bit more about treatment planning. And so this is a check all that apply. How would you simulate this patient for treatment? So the considerations here are, would you consider treating with arms up versus arms down akimbo? What type of CAT scan would you get? A 4D CAT scan, deep inspiration breath hold, helical CT, and then whether you would use a thermoplastic mask or not. Okay, so there's a 50-50 mix about arms up versus arms down, maybe slight preference for arms down. And then in terms of motion management, kind of a equal kind of consideration of 40 CT versus deep inspiration breath hold, and 60% would use a thermoplastic mask. So just a quick question, just a quick comment about like treatment setup for these patients. I generally will have them with the arms down akimbo for maybe two practical reasons. One is many of these patients also have neck involvement, and I'll use a thermoplastic mask for mobilization. And it's hard to, you can't have the mask and arms up at the same time. The other aspect, and this is more for a dosimetric potential advantage, is especially with patients that are female, with arms up, it actually brings more breast tissue in medially. And so you end up treating, when you're treating in the mediastinal area, you end up clipping more of the breast tissue. So actually having arms down will help your breast dose. And then important to just highlight, we need some type of motion management. And even if you do a helical CT, you probably need to add some type of empiric margin, which may not be patient specific for the motion. So this is her proton plan. We went with a technique called pencil beam scanning. It's more conformal comparatively to two other types of proton techniques, which are uniform scanning or passive scattering. And I treated her with free breathing. Her right arm was akimbo because we were treating the right axilla. And we treated her with two isocenters. The first one treating the neck, axilla, mediastinum. And then the second isocenter treating that lower paraesophageal lymph node that we talked about. And then as we're going through these axial slices, you can see starting in the neck area, how we actually came in with an anterior posterior oblique in the neck. And then as we're transitioning down to the level of the supraclav, mediastinum, we're actually using an anterior and posterior beams instead. I want to highlight on the upper right corner where we're in the lower axilla. Here we're actually using only a posterior beam in the axilla, so you can see that dose sparing to that anterior breast tissue. And then in the panel just below that, in the anterior mediastinum, then we're just transitioning to an AP only beam just to save dose or minimize dose to the lung tissue. And then in terms of the paraesophageal lymph node, we actually went with just a single posterior beam. As you can see there, you can see how we nicely spare that breast tissue and heart. But obviously being mindful that this target moves, and one of the considerations with pencil beam scanning is this potential risk of interplay, meaning that your target can be moving at the same time you're actually painting dose within a particular volume. So there is the theoretical potential of actually missing the target while you're delivering the radiation dose. So one way to mitigate that risk is not to put all your eggs in one basket, meaning use more than one beam. So in the mediastinum area, you can see we're using two beams, an APPA configuration. But here, because we're using a single beam, we paint it. So you just treat again with a PA beam. And this time we decided to do it 3 times because the motion was a little bit larger. Remember, this is at the level of the diaphragm. Her suit motion was about 1.2 centimeters. So we decided to do volumetric repainting times 3. And then how does this compare with IMRT? Well, here's a comparative plan here on the right. And then you can see here in terms of proton plan, the mean heart dose was about more than half reduced compared to photons. The left anterior descending max dose was about the same. The lung metrics also were more favorable with proton therapy. And I'll just highlight that if we think about risk of pneumonitis, in terms of mean lung dose, I try to keep it less than 13 to 13.5 gray. V20 we were able to meet was less than 30%, but V5 generally we like to keep less than 55%. And then lower dose, mean breast dose as well. So I had alluded to kind of this lower mediastinal lymphoma, and I just wanted to highlight there are various landmarks that may be used to define lower mediastinal involvement. The ILROG uses the left main stem coronary artery, which is in blue there. And then there's a study from the Institut Gustave Roussy that have used carina plus 3 centimeters inferior to the carina. And then I've used inferior left pulmonary artery based on the cardiac contouring atlas. This is the anatomic superior border of the heart. And I find it fairly easy to find on non-contrast axial images, which is to be noted because many of PET CT scans, unfortunately at staging, are non-diagnostic in quality. And why is that significant? Well, there's a nice study from the University of Florida, a dosimetric comparative study, in which they looked at 21 patients with lower mediastinal involvement as defined by the ILROG. And they created these 4 comparative plans. So protons versus photons. And then they did patients both with free breathing and a deep inspiration breath hold. The proton plans are in red, the photon plans are in blue. First thing just to realize that the deep inspiration breath hold, really the main benefit with the deep inspiration breath hold seen among these patients was in the lung volume, which makes sense. You're maximally inflating the lungs. And so you're actually, you can generally irradiate a smaller proportion. But in terms of benefit, in terms of heart or breast doses, it didn't seem to play out too well. And then the other considerations with protons versus photons, you can see that protons actually has better sparing of the low to moderate dose. But I do want to highlight, and maybe you can show Ryan, like in the heart volume toward the right at 30 gray, where photons actually has better sparing at the higher doses. And that's actually been, that's something that I think is, I would see in my day-to-day clinical practice as well. So challenging aspects of this case is, understanding the role of radiation after chemotherapy, especially non-standard chemotherapy. We are really fortunate to have such a wide array of different technologies available to us, but how do we choose among our toolkit of radiation techniques of what may be appropriate for one patient versus another? And then considerations of treatment planning for mediastinal lymphoma, given the challenges with motion management, for example. And I do want to highlight that the ILROG has guidelines that were published in 2018. Ryan, if you could hit just one, thank you, which are shown here, looking at proton therapy for adults with mediastinal lymphomas, and it's a great reference if you have further interest in reading more.
Great, thank you, Dr. Sang. So let's move on with Dr. Imber's case, and then we'll get to questions at the end. So if anybody has questions, just put them in the chat, and we'll circle back. Dr. Imber.
Thanks a lot. So we're going to switch gears again from Hodgkin lymphoma now to some more forward-looking topics of trying to explore how radiation might interface with CAR T cells or other cellular therapies. And the case I'm going to present is actually a really challenging case, but I thought it highlighted several really important teaching concepts about how radiation might play a role with CAR T in the future. So this is the history of this patient. This was a 59-year-old gentleman who had some flank pain, eventually got cross-sectional imaging that showed a pretty large mass in his retroperitoneum, extending along the right aspect of his aorta. There were also a couple of other periaortic and possibly some disease in the mesentery as well. He eventually got a CT-guided biopsy, which showed diffuse large B-cell lymphoma. He got a PET scan as well, which really just confirmed what we knew from the CAT scan, but it was very avid, 21.4 SUV. And at this point, it had already grown, even in the short period of time from his first imaging. It was now about 12 centimeters in max diameter. So this patient went on to get standard of care for diffuse large B-cell lymphoma, which is 6 cycles of R-CHOP chemotherapy. And then for his end of treatment PET scan, unfortunately, there was already new and worsening abdominal adenopathy. This was in the area where he originally had disease, same SUV. And he went on to get another biopsy, which would be standard of care, and just confirm that there was still active diffuse large B-cell lymphoma that was there. So this patient has primary refractory disease. And my first poll question for the group is, what would be your most typical next step in management for this patient? Would you consider radiation? Would you consider more chemotherapy with the intent of possibly going to a transplant? Would you collect his lymphocytes, possibly with the intent of going to CAR T cell or chimeric antigen receptor therapy? Or would you talk to him potentially about clinical trials for non-chemotherapy options? So most people are thinking that this patient should go for a transplant with maybe radiation as a second. And if we go to the next slide, I actually think maybe all of you are somewhat right, depending on the situation. But I would say that most people did go with what I would say is the most common strategy, which would be for patients who have the intent of going to transplant, there would be a second line of chemotherapy, usually something like ICE chemotherapy or DHAX or DHAP chemotherapy. And then if the patient is achieving a complete response after the chemotherapy, they would go on to a stem cell transplant, plus or minus radiation therapy. But what you'll see in that second portion of the right side on this consolidation is that for patients who achieve a partial response after that chemo, this is where CAR T cell therapy might come into play. So it really would depend on what the complete response is to that next line of therapy, what we would do with this patient. What I'll say about this is that this is the current NCCN guidelines, but I suspect that this is in flux. And the reason I say that is there is a lot of enthusiasm from our hemonc partners to consider moving CAR T cell therapy earlier in the treatment paradigm. And there are clinical trials which reported recently, which suggest that maybe it might be advantageous to consider CAR T in the first relapse. So instead of going to transplant, considering CAR T cells in that situation. That is not standard of care yet, but it might be in the future. But this patient was treated a few years ago and did get what most of the group proposed, which was a second line of chemo with rice chemotherapy, got 1 cycle, unfortunately clinically progressed even after that 1 cycle. So the autologous transplant was aborted. He was put on a second regimen of polatuzumab and bendamustine, and unfortunately also progressed through that as well. So this patient had very refractory disease. And I just also wanted to give a sense of what kind of patient this was. This was a gentleman who was quite sick. He had had 50 pounds of weight loss since his diagnosis. He was persistently nauseated. He was on high doses of narcotics. He was on prednisone for the hope of trying to cytoreduce him. He was functional, but this was an ill guy. If you want to go forward. So there were a couple of options that were discussed with him at this point. One is a regimen called tafasitamab and lenalidomide. We have a couple of protocols here. So bispecific antibody was discussed with him. CAR T cells were discussed with him, either commercially available CAR T or an experimental trial, or maybe palliative radiotherapy. So moving on to the next slide, I just wanted to give you a sense. This is what his imaging looked like, really confluent retroperitoneal disease from the renal vessels all the way down into his pelvis. We can go to the next slide. So I just wanted to start off, this gentleman opted for CAR T cell therapy. For those who are in centers where there isn't a big CAR program, I just wanted to give a sense of what is that. So CAR T cells are in a form of adoptive cellular therapy. So these are autologous products where a patient's blood is collected, the T cells are removed, and then these T cells are genetically modified using viruses to express a specific receptor on their surface that recognizes a particular tumor antigen. And once they've been transduced virally, they're then expanded. So you have millions of these T cells, which are grown. The patient then receives chemotherapy, usually a lymphodepleting regimen to try to make space for all of these autologous T cells, which will be given back. And then the patient receives their own engineered T cells back. And this is a long process. This whole process, in the best case of scenarios, takes about 3 weeks. In the worst case of scenarios, can take up to 6 weeks, sometimes even 2 months for this to happen. And you can imagine, like a patient I described, he was quite sick. So there was a period of time where we are waiting for this product to come. We can go on to the next slide. So the important thing about CAR T cells is that they require recognition of a particular tumor antigen. So what is the tumor antigen that most of the heme-focused CAR T cells are recognizing right now? Is it BCL2, CD19, CD20, or CD56? So about 54% of the group said the right answer, which is CD19. CD19 is a B cell marker. It's ubiquitously expressed on both benign and malignant B cells, and that is the target of all of the commercially available products for heme malignancies at this point. There is a lot of interest in exploring other targets. For example, in multiple myeloma, there is now an FDA-approved product that looks at BCMA, which is a tumor antigen there. There was a lot of enthusiasm trying to identify specific antigens for solid tumors and hoping that CAR T might make a way into those paradigms as well. So stay tuned. This is an area of very intense research. We can move forward. So I just wanted to give a little bit of a sense of how CAR Ts work, and you can click the next, Ryan, as well. So basically on top, this is the normal T cell interaction where an HLA presents an antigen, either with a dendritic cell or the tumor cell itself, to the normal T cell, which then triggers expansion and a cytotoxic response. Chimeric antigen receptors are on the bottom. These are purposefully engineered, so you can see that there is a receptor that binds to CD19, which is a normally appearing antigen on the B cells and the lymphoma cells. And then that antigen receptor is attached intracellularly to CD3, which is the normal T cell signaling component, and they're engineered to contain a co-stimulatory domain to really enhance that signal to make sure that these T cells expand properly. And on the right, you see that there are already 3 different products which exist. Very similar in concept. They all bind to CD19. They all have that CD3 signaling domain. There are 2 different co-stimulatory domains which are currently being utilized. And the thing I wanted to highlight is that 3 different products, all with very remarkable efficacy. So overall response rates for these products have been remarkable for a very sick, challenging population, almost as high as 80%, sometimes 90% in certain types of lymphoma. And 60% of these patients are achieving complete responses. So this has been revolutionary for heme malignancies in the refractory community. You can go to the next slide. So DLBCL is just one indication, so I don't choose that one, but there are other lymphomas where CAR T cells are being used. What is the one type of lymphoma that's listed here where there isn't at least one commercially available CAR T product? Is it follicular, anaplastic large cell, mantle cell, or primary mediastinal B cell lymphoma? So actually, close tie between follicular and anaplastic large cell lymphoma, and those who guessed anaplastic large cell lymphoma, you are right. So if we go to the next slide, just wanted to give you a sense of the names of the products that are out there in case you start hearing about them. Kymriah or Tisacel, Tisagen Lechlucil, Axicel or Yescarta, Breyanzi or Lisocel, Lisocabtagene. These are the names of the CAR T products which are approved. And for now, they're used in DLBCL, transformed follicular, certain lymphoblastic leukemias, primary mediastinal B cell lymphoma. There is already approval for follicular lymphoma. and mantle cell lymphoma as well. And I expect that this list of indications will increase. Nothing in the T cell realm as of yet. Go on. So would this patient meet criteria for CAR T cells? The answer is yes. So in general, patients as of now, they need to be refractory through at least 2 prior lines of systemic therapy, which this patient was. Patients can have had an auto, but they don't need to. They don't need to be in complete response, as we discussed. They can still have disease. They need to have adequate performance status. And they need to express CD19, which is the target that the CAR T cells go after. So this patient met criteria and agreed for CAR T cells. And the one thing I just wanted to say is that CAR T cells are amazing. The responses are 80%, but they are not going to be amazing for everybody forever. What you see, these are Kaplan-Meier curves from 2 of the pivotal trials, TISA-GEN on the left side, Axi-cell on the right. What you'll see is that there's actually a pretty sharp fall off, and then the curves plateau. So this is progression-free survival for 2 of those products, and it's a very similar trend where about 50% of patients will have a durable response to these regimens. You can continue. And the open question is, can we integrate radiation with CAR T cells to perhaps improve some of these outcomes? And this is an area of research, but there are a couple of different roles of radiation that have been proposed. One is bridging. So as I mentioned, there's a 4 to 8 week window where the patients are waiting for their product. Can we integrate radiation into that time period to perhaps bridge that gap? Some other ideas are, can we give low dose radiation after the patients get CAR T to try to augment the immune response? Can we perhaps salvage patients who fail after CAR T with radiation as well? So for the rest, I'm just going to give a little bit of information why people are excited about bridging radiation. One thing that is now quite clear is that the amount of disease that a patient has at the time of they're getting CAR T cells is prognostic. So on the left, this is an analysis from the Moffitt Cancer Center. And what they did was they stratified their patients who got Axi-cell by the metabolic tumor volume, or how much lymphoma did they have at the time they were being considered for CAR T cells. And what you'll see is that patients who had lower burden, that blue line, do better than the patients who had more disease, the red line. So this raises a question, can you use radiation to perhaps cytoreduce or debulk these patients? And if you go to the next slide, I'll give you a sense of why people are excited about that. You can go on, Ryan. This was a patient of mine, a lot of bulky abdominal disease, had all of the high-risk features. She ended up getting 3 × 10. And just 3 days after she completed the 30 gray, you can see that she had a tremendous response. So these patients can respond quickly. And if they do respond, they often respond durably in that area. Radiation is one strategy for bridging, but there are other options as well. Maybe if you push the next. This was a nice analysis out of MD Anderson, where they looked at the options for bridging. So some people are getting radiation, other people are getting systemic therapy. And this was a small series, but there seemed to be an early signal that radiation bridged patients, that red line on the Kaplan-Meier curve, had a similar progression-free survival to patients who didn't get any bridging, that blue line, presumably because they didn't have enough disease to warrant it. And there seemed to be a small signal that perhaps the radiation bridge patient, that red line, have some advantage against patients bridged with systemic therapy alone, that green line. This is something that a lot of centers are excited about and is an area of active research right now. You can go forward. You can keep going. And the one thing I just wanted to say very quickly is that, we spoke about cytoreduction, but there also is a potential rationale for using low dose radiation to augment the immune response. And I don't have time to really go into it, but this is exciting work from Carl DeSelm and Michelle Sadelaine that suggests that low doses of radiation might actually make the CAR T cells work better within the tumors that are irradiated. And this is something that numerous centers are exploring right now. You can go forward. And this, we actually, that concept that, there is a local immune effect within tumors suggests that you should try to be as comprehensive as possible with irradiation. And we see some clinical examples of that. So this is a patient on the left that was treated at MSK, had a lot of disease, ended up getting low dose radiation to her right leg for palliative reasons, got CAR T cells. You can see at 1 month post-treatment, that PET scan looked very good. 2 months post-treatment, the patient had relapse basically everywhere outside of that field except the area that was irradiated. Sort of a similar story on the right. This is a case from MD Anderson, a patient with a bulky abdominal tumor, very low dose radiation, relatively speaking, to the abdomen, ended up relapsing outside of the field, but there was something special about the place that was controlled. Whether this is just because these patients are irradiated or because there's some special sauce that's happening and an immune effect within that tumor, I think that that's an open question right now, but definitely thought-provoking. Go forward. So this patient is convinced after your speech, if you were going to give this patient bridging radiation, the one with all that bulky retroperitoneal disease, what dose would you consider? 2 by 2, 2 by 15, 3 gray times 10, 2 gray times 20 to 25. There was no disease outside of that bulky retroperitoneal mass. So most people said 3 times 10. And if we go forward, that was ultimately what we chose to do. I would say that there probably is no right answer. For bulky disease or single areas of disease, we have tended to favor 3 times 10 here at MSK. I know other centers have favored using higher doses, something more like a definitive dose of 2 gray times 20 to 25. And this is a patient where they had a single area of disease in the retroperitoneum. They often look much more like the patients I showed a few slides ago with diffuse disease all over. So I get asked the question a lot of how do you design radiation fields in this situation? So my general principles are, if I can be comprehensive safely, I do that. If not, I typically follow principles of palliative radiation. If there are sites that are painful or going to be compressive or going to cause problems for patients, I try to target those. And I also try to aim for cytoreduction of high-risk lesions. And some of the high-risk criteria that I use comes from a really nice paper from Moffitt, where they identified some risk factors for local failure after CAR T cells, which are things that make sense. Large diameter, greater than 5 centimeters, SUV greater than 10, and extranodal qualities. And if you click next, you'll see that they were able to separate curves in terms of local control after CAR T. These are patients who were not bridged, suggesting that we should perhaps intervene in these lesions because they have a high risk of failure after CAR T cells. So moving on, I just wanted to very quickly show you how we contour these cases. Basically, the GTV was all that retroperitoneal disease. We did a CTV that carved off the bone, and then a 1 centimeter PTV expansion. We can move on. Just to give you a sense of the planning, we used a VMAT plan here, which was the original component was 3 times 10, as people recommended. We can go on. And interestingly, this patient, we did a PET scan right after 30 gray. This patient didn't budge at all. Basically the same PET scan after that 30 gray. So there was now a debate. Should we take this patient to CAR T cell knowing that there was really no cytoreduction at all? Should we give some more radiotherapy? Ryan, if you go to the next slide. The other interesting clinical development that happened was actually there was a delay in getting the CAR T cells for this patient. It was another 2.5 weeks. So we actually decided to give another 5 fractions of 3 gray, so a total of 45 gray and 15 fractions, if you move on. And I would say that there is a growing trend to try to use these higher doses for more localized disease. Next slide. Basically, this patient really didn't budge again, had stable disease in field, out of field, got a progression. At this point, the medical oncologist said, we're just going to give them CAR T cells. So they ended up getting axi-cel. If you go on to the next slide, some of the side effects that we monitor for are cytokine release syndrome, basically fevers and problems with blood pressure, neurotoxicity, and low blood counts. Part of that is because we are targeting CD19, which is on normal B cells as well. We can move on. So how did this patient do? This is my last slide. Basically, 30 days after CAR T, had a partial response in the area that was treated. And unfortunately, 60 days later, relapsed in field. So despite everything that we threw at this patient had very, very refractory disease. And I use this example not to be depressing. There are a lot of patients who have a much, much better response to this combination, but more hopeful optimism that we need to do a lot more research and to figure out how to best use CAR T cells, but also how to integrate radiation back in. So with that, I think I'll stop. Thanks very much.
All right, thanks everybody. We have a few minutes left. I know there's a couple questions that came through. Someone asked any tips for managing a patient with early stage unfavorable Hodgkin lymphoma started on Stanford 5 due to shortage for 2 cycles. PET after shows a minimal response, got ABVD for 2 cycles with a complete response on PET. So 4 cycles total. I guess that fits not directly with any of the cases, but any tips from the panelists?
It's hard to comment without more details, but the fact that they did not have a good response after 2 cycles, that has been shown to be prognostic, makes me a little bit worried. And then the other consideration is, would they be considering additional chemotherapy just beyond 4? So would they be aiming for 6 cycles?
Yeah, I can make one quick comment. Hey, I'm John Plestach from Penn. Thanks for letting me be a panelist. I would say for patients with Hodgkin lymphoma, anytime you have the chemotherapy sort of at lower doses, adulterated doses, not on time, dropped agents, you want to make sure that you're not cheating on the radiation doses and volumes. So you would probably not want to discount dose. And, sometimes we even treat patients like that to 36 gray rather than the standard 30 gray, even when they're in a complete remission if the chemotherapy has been too wacky.
All right, fantastic. Well, thanks again to the speakers. There's just a couple announcements. Our website has all the previous lectures that Rover has sponsored. And there's some contact info here if you guys have questions or anything. We wanted to thank our coordinator, Nav, for doing a great job again. Everybody that's in attendance will get a survey. Please fill those out so we can help make these better in the future. And then just to shout out, our next series is going to be a great one on safety fundamentals in radiation oncology. And we have a really good panel of physicians and physicists talking about incident investigation. So that'll be great. It's March 4th. You can sign up on the Rover website. So with that, I think we will wrap it up. Thanks again for attending.